All right, so we talked about MIs and recognizing MIs, and then about getting percutaneous coronary interventions or cabbages or whatever it might be to get their MIs recovered, but sometimes you still have complications of MIs. This is acute to about 2 weeks to 3 weeks. So about not worst case scenario, but 3 weeks out, you can still have complications. That complication being called pericarditis, right? Can be a complication of an MI. And it's not because of infection or anything, it's because just of an inflammatory response. And they call that Dressler's, and the only reason I bring that up because it fits the mnemonic, right? The mnemonic being Darth Vader, right? So D, Dressler's down there. The first D is death, right? So you can die from your MI acutely, right? A next complication would be arrhythmias, and there's a lot of arrhythmias that can happen. And we're going to split our arrhythmias into supraventricular and ventricular, right? So if you have your heart right here, right, you can split it into supra up the top, supra, and ventricular, right? So they can have ventricular what? Ventricular tachycardia or VFib, right? Or even torsades, which is fancy ventricular tachycardia or polymorphic ventricular tachycardia. And they can have supraventricular tachycardias, right? They can also have supraventricular dysrhythmias or bradyarrhythmias, such as what's an example of bradyarrhythmia?
What, bradyarrhythmia?
Mm-hmm. Bradycardia, yeah. So bradycardia, or they can have a first-degree block, a second-degree block, third-degree block. They have idioventricular block. They can have all kinds of blocks that can happen as well. Or they can have supraventricular tachycardias, which is an umbrella term for all kinds of arrhythmias that might occur in the atria, right? You have AFib, you have A-flutter. Over there, you have SVT, technically called paroxysmal SVT. You can have multifocal atrial tachycardia. There's all kinds of tachycardias that can occur above the AV nodes, right? And that's one of our operative spots that we're going to give medications to fix, right? And there's medications we're going to give for down below as well, right? Usually ABCD meds, which we'll touch base when we talk about AFib and A-flutter and such. These are the meds we give for supraventricular. As far as ventricular rhythms, basically the go-to medication that actually doubles up on both sides is amiodarone, right? Amiodarone is usually a go-to. It covers ventricular arrhythmias and it covers supraventricular arrhythmias. But something like B for beta blockers does not cover both. There is one beta blocker. So in the back of the room just shifted up the glasses like, yeah, what about sotalol, right? So yes, sotalol does have ventricular activity, but all the other ones only affect the supraventricular or atrial rhythms, right? They are AV node suppression agents. They suppress this AV node so it doesn't let those extra activity get down to the ventricles and cause tachycardias, right? And then you got C for calcium channel blockers. So and specific ones, diltiazem and vratmo, the only two that are used to suppress a really fast supraventricular tachycardia. If you give diltiazem for VTach, you get laughed at. No, I'm kidding. So that's not going to be something that is going to work on a ventricular rhythm, right? But amiodarone does. Amiodarone does for both teams, right? And the last one's D. D stands for what's another medication you might give? IV push, sometimes PO. It's used it's made from a plant, right? It's been from the early 1800s. Van Gogh overdosed on it, and he saw yellow circles everywhere, and he was vomiting all the time, a little crazy. It's called digoxin, right? So digoxins also can be used as a AV node suppression agent, right? And then also we have other guys out there like lidocaine, right? A&L forever, right? So anyways, we have amiodarone and lidocaine. Those are usually our go-to agents for ventricular arrhythmias, right? So arrhythmias can happen because you have inadequate flow to your ventricle or to your atria, and it freaks the heck out. So what's going on? It's going to start fibrillating. So, well, I'm getting nervous, right? It's going to like a little panic attack, right? It starts fibrillating, whether it be afibrillating or V-fibrillating. It's going to fibrillate, right? Or if that doesn't happen, this is a stressor to the body, right? And when you have a stressor to your body, when you have low oxygen flow to your lung, to your system, whether it be your brain or specifically the aortic arch or the carotid bodies, what gets triggered? The SNS fires off. Or you have cardiogenic shock, let's say, and you have low blood pressure. You have low blood pressure to your baroreceptors, your SNS fires off. You start getting lactatemia or lactate elevation because your tissues are not getting good cardiac output. That's going to raise the lactate, and that's going to do what to my pH? Decrease the pH, right? So all these things are triggers for the SNS response. And your SNS is going to do its thing, and it's going to make you breathe faster. It's going to make you pupil dilate. It's going to make you get diaphoretic. And it's also going to go to your heart and tell your heart, raise the heart rate, please. and the heart rate's like, God, you got it, boss, and it's like, it doesn't work good, right? And it starts going to VTAC or polymorphic VTAC or AFib, whatever it is, right? So usually an SNS response, it's going to do what it can. It's going to go to, it's like when you have a really bad car, a big lemon, and you go out there, it's my SNS response, let's go, right? And then the wheel might fall off, something might happen, right? So that's kind of what's going on with the MI. The part of the heart is failed, right? And that they're high risk for arrhythmias, right? And then what else? Rupture. So the heart can rupture. That's scary, right? So the free wall can rupture. There's a few things that can rupture. One of them being our papillary muscle, right? It's fed by the PDA. One part of it is fed by the PDA, and that can then be that can rupture, right? And what's the whole purpose of a papillary muscle?
Open and close.
It's a parachute system. It holds shut the mitral valve, because when you contract your ventricles, you pump blood out into your aorta, right? You don't want that blood to go into your left atrium where it just came from. So it's a little parachute that holds down the mitral valve leaflets so that your blood goes the right direction, right? So they might hit the mitral valve, but then it'll make a little U-turn and go out the aortic valve like it should. But if you have papillary muscle rupture, then that's not going to work. So you're going to start hearing a murmur, right? Is that murmur going to be systolic or diastolic?
It'd be systolic.
It's a systolic murmur because that valve is not able to be shut during systole. So you're going to hear it best during systole. And we have a whole section of valves we'll talk about. I'm going to start beatboxing. You'll be looking forward to it. All right. So yeah, so you got rupture of the papillary muscle. You can also have rupture of the free wall of the ventricle. Obviously, that's the worst case scenario, right? The wall does not repair like it should, and now it's thinned out, right? Or it can become aneurysmal, where it starts bowing out, and then it can rupture, right? And obviously that can rupture into the space around the heart, which is called the what? Pericardium. Remember I told you 5 cc's will do it, right? So that's going to be 5 cc's real fast, right? Because your ventricle holds how many cc's on average? For a normal stroke volume is about 70 to 100 cc's. So normal person puts out about 70%. It's about 150 cc's is a normal stroke, LV and diastolic volume, right? So that's going to 150 cc's is going to go right out into the pericardium, or it's going to leak over time, but it's going to get sick real quick, right? And you get signs of what kind of what? Tamponade, which are what? Bextriad or low voltage EKGs. We've got someone fancy over here. And we got pulsus alternans as well. And what else? Bextriad is the muffled heart sounds, which I won't believe you, unless it's like a young person. And what else?
Widening pulse pressure ranges.
You get pulse pressures that are going to be what? Narrow or wide? Narrow, right? So you're going to not going to be able to put out a systolic pressure because your heart's squeezed, right? And your SNS is like, what the heck? Where's my blood pressure? And it's going to start squeezing down the diastole. So you're going to have a narrowed pulse pressure. But you're also going to definitely have a low blood pressure, right? Because you're not able to fill the ventricle or even the right atrium with blood because it's all encased in all this fluid, right? All this blood. Okay, and then of course low blood pressure, and because you can't fill the right atrium, it's going to start backing up into the neck, and you get JVD, right? So you got tamponade is our T there, right? So tamponade can happen because of this LV free wall rupture, or it can happen because of pericarditis 3 weeks out, right? One of the two will happen. Or if they go for a PCI, they can poke through the coronaries, and that can rupture as well. Okay, and H, heart failure, right? They can have acute heart failure where they're just, bam, their EF's reduced from, normal 70 to 80%, and then you realize something like someone cardiac arrest from MI or something, they're now down to like 10%, right, or even 5%. So they can have an acute decompensation, and they might bounce back a little bit if they make it out of the hospital, or someone might just go from 60% to 40%, right? They can have a complication of CHF as their consequence of that MI. And of course, CHF can be to other reasons. Over time, chronically, it can happen. But this is one of the most common reasons to develop CHF, is they developed MI, or ischemic heart disease, right? So they get CHF, and the worst case scenario when we talk about CHF in our next lecture is the complication of cardiogenic shock, right? So they go into cardiogenic shock because the heart cannot pump effectively. It's not pumping blood out to the body, and therefore the body gets upset, and the SNS is going to fire off, and that's not going to help the heart anyway. And then you start getting cool extremities because of that, and also low cardiac output, and that's going to lead to lactate elevation and cardiogenic shock and such, right? So cardiogenic shock is a reason for as a consequence of a CHF, but also that LV free wall rupture. That can do it as well. And then valve disease, right? So this CHF, your chambers get dilated and more dilated and more dilated. And before, if the valves shut nicely, but if you dilate those chambers out, they're not going to shut nicely anymore, right? You're going to have a lot of free space for things to regurge through, right? So you get murmurs that can develop as well. Okay, and also we mentioned with the papillary muscle rupture, we can also get a murmur right away, right? A systolic murmur. And then with that dilation of the chamber, you get a new sound, right? You get a new S3 that can happen as well. And then aneurysm of the ventricle that we mentioned, right? It can aneurysm out first before it ruptures, and then it will then eventually just rupture, right? The other rupture I didn't mention was, besides the LV free wall and besides the papillary muscle, is the septum, so the ventricular septal defect, right? So right here, between the right ventricle and left ventricle, that wall can rupture, right? If you get a septal MI, like with a LAD that's feeding the septum, and then it just dies off, right? Or doesn't repair because they didn't get flow in time. They went to the hospital, they were gonna try to sleep it off, right? And they finally go in later, and they go to Ridgecrest, and then like they say, oh, we give you thrombolytics, but it's been more than 12 hours. We can't give it to you. We're gonna go throw you to Palmdale because you still have ST elevation, and we can't, and then we go in there, and it's like, yeah, your LAD's down. We're going to try medical therapy, right? So that can lead to the ventricular septal defect or ventricular septal wall rupture, right? And you're going to hear a murmur definitely when? During systole or diastole?
During diastole.
Systole, for sure, right? You might hear a little bit of during a little rumbling or diastole as it fills up the chambers, but definitely when you squeeze those ventricles, it's going to squeeze into the right ventricle, right? So it could be like a holosystolic murmur. Okay, and you can talk about Dressler's, and then E for embolism. So this aneurysm down here is not without problems, right? That aneurysm it's a space in the ventricles that is not accounted for, and that can then start forming a clot, right? Because it's not moving around effectively like it should, and that clot can then embolize, right? That thrombus can embolize into the brain, right? Or cause a stroke. And also you get embolisms because what if we have a supraventricular tachycardia such as AFib, which is irregular, right? And they go home and they have chronic AFib, and now they could develop a clot easily. So when they have AFib on discharge, you want to make sure they're on what kind of medications? Anticoagulants with some, yeah. So DOACs are the new ones on the block, right? Warfarin was 2005. So now it's DOACs. Those are the ones that we should be on. Okay, and then lastly, recurrent. It's like it's not just your first MI. It's like, oh, that was troublesome. I had one when I was 55. I guess I'm glad I'm not going to get one anymore. No, you're high risk to have a recurrence of an MI. I think it's like upwards like 30% or so. All right, so that is, and then now you're back to square one, right? Your next MI could be death. Your next MI could lead to pericarditis. Your next MI could lead to a really more profound CHF, right? So that's the idea. And obviously they have to take their dual antiplatelet therapy in the next 3 months to 18 months, depends on risk factors, so they don't develop a reocclusion of their stent, right? We often get patients in here where their stent reoccluded, okay? So that's the idea behind your complications. We get ventricular arrhythmias very acutely. We can get cardiogenic shock. Sometimes they have to be put on mechanical circulatory devices, right? MCS, myocardial, I'm losing the abbreviation, but they get mechanical cardiac support, right? MCS. They're getting support mechanically to support their heart, right? So like a balloon pump or an Impella, VA ECMO can be something they can use. We mentioned bradyarrhythmias can happen, ventricular arrhythmias can happen. They get a stroke straight up with a AFib, or whether it be a thrombus in the heart, and this can lead to more wall ruptures, and that can then lead to, of course, more complications. All right, so we're going to kind of separate the slides into different categories. We'll do a little overview slide, and then we'll talk about the mechanical complications, late complications like pericarditis, and then electrical complications, which will get us into the ACLS territory. Okay, so CAD, that's what caused this whole problem in the first place. That's where we started with our cardiac lecture, is CAD and leading to an MI. So, CAD, they come in for ACS. That ACS could be just unstable angina, or it could be an MI of some sort. Two flavors of MIs. What are the two flavors? NSTEMI and STEMI. And they found a new flavor. They found the 32nd Baskin-Robbins flavor, which is called an occlusive MI, an OMI, right? So an OMI is occlusive, where it's completely occlusive, and yes, it causes ST elevation, but it can also cause, Scarbosis criteria. It can cause de Wheelen's T waves and de Winter's T waves and all the other fancy equivalents to an MI, or a new left bundle branch block, right? So these are all occlusive MI symptoms. So there's occlusive and non-occlusive. That's like the new terminology in the last 5 years. Okay, so you got in-STEMI or STEMI, and then you get structural damage due to that MI, like, you come out of the hospital and you have structural damage, right? And that can lead to, like we said, dysrhythmias such as VTAC or VFib, or it can lead to valvular problems and cause me to go into AFib because my chambers are much more expanded now. So now that one little atria trying to go from point A to point B has to go all the way around, right? And then it's used to going from point A to point B, but now this guy's like, what about me? What about me? What about me? And now you're in AFib, right? And then, of course, we mentioned heart failure can happen, and the heart failure leads to MI. So now we're back to square one, right? So we're back all the way to the top again. And then the heart failure itself leads to murmurs what else? If the papillary muscle rupture didn't cause it, the CHF definitely will cause it, right? Causing murmurs to occur. And then dysrhythmias, CHF, again, the atria can well out and because of the murmur, and also the ventricles can get bigger, causing more dysrhythmias to happen, ventricular rhythms or atrial rhythms, right? And then we mentioned the most serious complication of cardiogenic shock, or of a CHF, is your cardiogenic shock, right? And that can happen acutely with a large MI, or it can happen over time with worsening CHF. And then murmurs, as we mentioned, heart failure can do it, or dysrhythmias can do it. And of course, a murmur can lead to dysrhythmia and development of where you need to get that replaced if you can, or be on anticoagulants at least. All right, we mentioned rupture of the free wall, the septum, and the papilla, and pericarditis, usually about 3 weeks in. And you get this tamponade that can happen as well. If it isn't causing pericarditis, the other reason for tamponade would be the rupture of the free wall over here, right? And that usually aneurysms out first, and you'll start getting clots forming, and that's now can embolize. And of course, our ventricular septal wall can rupture as well. Okay, and then ventricular thrombi, as we mentioned, and then of course, you're not out of the woods. You can still have an MI again. Okay, so here's an example of a ventricular thrombus here. Okay, so the thrombus is sitting there in the clot, and that's called a clot in transit. Now it's gone to the easily. That's the left side that we're looking at. It's easily gone to the brain. That's the first shot, right? You got 2 shots to hit the brain off the aorta, right? And if it doesn't cause that, right, we can also get some CHF. You can see the ejection fraction on the right is much worse than on the left. Okay, so mechanical complications. So mechanical complications, as we mentioned, the pump itself can fail. So that is your cardiogenic shock. It can happen from long-standing CHF, or again, it can happen acutely from a very, very large MI. And how do you know you have cardiogenic shock? Usually, you're not wrong if you say most shocks have low blood pressure, but usually we try to catch it before they get low blood pressure, right? They look like they look sick, or they look like they're really cool extremities, and then eventually you will see their blood pressure start dropping, right? And also, since you're getting poor perfusion to your extremities, what lab value will go up? Lactate, very good. So your tissues are not getting oxygen. The reason why they're not getting oxygen is because of the lack of perfusion, right? Lack of delivery of oxygen. Okay. Again, myocardial rupture, septal rupture, papillary muscle rupture. So what kind of rupture is this? That is rupture of the free wall, right? So all the walls are free. They don't cost money, but you have the LV free wall, right? The LV is rupturing, and then that can rupture into the pericardium, and now we're in trouble because now that's going to start accumulating acutely, right? And that's going to then compress the heart. It's going to tamponade the heart. It's going to prevent it from expanding, right? It's considered an obstructive shock. It's obstructing the flow of blood, right? It can't contract, so then it can't push blood out into the aorta. Your blood pressure is low, right? So low blood pressure, part of Beck's triad. And also we can't fill our, sorry, change colors, I promise. We can't fill our atria with blood as well. So it all backs up and we get JVD, right? And obviously muffled heart sounds because it can't contract, right? So that's tamponade that can develop from a LV wall rupture. And that usually happens when you have a transmural MI or an occlusive MI. that goes all the way through the wall. Mural meaning wall, right? It goes all the way through the wall, and if that doesn't get, reperfused within 90 minutes to a decent amount of time, then that can then easily rupture. Okay, it's also associated with thrombolytics, right? That's why cath lab is a little bit better, right? So, but thrombolytics, yes, can be given for a STEMI, but they put you at a higher risk for a free wall rupture, an LV free wall. We also mentioned NSAIDs, right? NSAIDs do not, even if you get that PCI and they go home and start taking their NSAIDs, that's going to impair the repair of the walls, right? It's not going to, because of the prostaglandins, which yes, cause pain, but also the prostaglandins also help with the recuperation of the muscle, right? Or the building of the muscle. So the muscle is not going to repair as well as it could, so it's going to lose the internal structure, right? And that can easily pop open. All right, and then what else? So the septum fed by the LAD or papillary muscle ruptures, that can lead to a murmur, no problem, right? That's where you can easily get a papillary muscle ruptures over here. This is a picture of the ventricular septum wall that might rupture as well. On the right here, you can see the posterior descending artery feeds the papillary muscle. That's like a zooming in on the papillary muscle, and the left circumflex does feed a little bit as well. But that's obviously there's a complication, is that papillary muscle can fail because our left circumflex, our PDA gets blocked, and then now we have a new murmur on our hands, right? So that's why it's important to assess that. Okay, so cardiogenic shock and myocardial free rupture, ventricular septal defect, and papillary muscles, right? Tamponade, 85% of the time, that makes sense, right? Because it's rupturing into that pericardium. And if 5 to 10 cc's will kill you acutely, that makes sense, right? So you notice whenever anybody has any cardiac problem, what do? Like Oprah, we get everybody a what? You get an echo, you get an echo, you get an echo, you get an echo, right? So anybody has cardiac problems, they should have a 12 lead and they should have an echo. That's usually pretty standard. And usually the x-ray is a close third, right? Because you're going to see, oh, look at that CHF in their lungs. All the lungs are filled with fluid now, right? So that's a close second.
What's the reason why thrombolytics can cause a free wall rupture?
Because you can't repair, it's breaking the clot that was formed there in the first place. Okay, thrombolytics are at risk for myocardial free wall rupture. Okay, and yeah, we might have to do mechanical cardiac support sometimes to support the heart, especially in cardiogenic shock. That's usually where we're going to see the most use of like Impellas or ECMOs or balloon pumps, right? Balloon pumps only support like 0.5 cardiac output, whereas an ECMO is up to 10 liters it can flow. An Impella, the one we have is up to 4.5 or something like that, 4.2 or something. But there's different flavors of mechanical support. All right, so then late complications. So those were like acute complications can happen in the first hour to 24 hours. These are more later complications. We can get an LV aneurysm that can start developing. So that didn't repair well because they took NSAIDs or they got thrombolytics or they have a really profound STEMI, and it's not going to repair as easily as they could. And their blood pressure is still high, it's not under control. That puts extra stress on the LV, and that's going to start bowing out and bowing out and bowing out until it ruptures. Right, and the only way to fix that is with open heart surgery. You can't just treat it medically, right? That is something that needs to be fixed. But you can see it on EKG. You'll see really deep Q waves, right? You'll see persistent ST elevation after their cath or on discharge, right? Like day 2, day 3, you're still going to see that ST elevation not go away. Right? And just FYI, after cath lab, a patient should not have ST elevation unless they said, oh, we couldn't do anything, right? That was way too far gone. There was this, we can't do X, Y, or Z. But this new ST changes that are persistent, that's a sign of an LV aneurysm. And the Q waves that are persistent, right? They have impressive Q waves, right? And they need to be anticoagulated if they have an aneurysm, otherwise that clot is going to start forming, right? So that is a concern. All right, what else? So LV thrombus, again, can form when you have an LV aneurysm, and LV thrombus can also form when you have really bad CHF, right? So one of the therapies when we talk about CHF is, it's called CRT, it's called cardiac resynchronization therapy. Not the political version, but that was really hot. But anyways, it's going to be depolarizing both ventricles at the same time, right? It goes in the LV and the RV, and it's going to depolarize and make sure the ventricles are nice and synchronized. So we're not getting this abnormal flow that's going to put them at risk for a clot formation. And just not only to say if they develop AFib, that could put them at risk as well. All right, and then pericarditis. So they're not going to really get CHF with this, but they will get tamponade if they get severe, enough, and that usually happens about 3 weeks in, 3 weeks out, I should say. Okay, so over here,
The inflammatory.
it's just from the inflammatory process from like repairs and such. Okay, so an LV aneurysm, that persistent ST elevation, right? So you got LV thrombus that can occur. It can occur soon, but it can also occur afterwards, if they're not on anticoagulation, right? They should be anticoagulated. And then pericarditis is also a complication that can develop from a MI. All right, so then electrical complications. So your electrical complications, you got bradyarrhythmias and tachyarrhythmias, like we mentioned. You have supraventricular and you have a ventricular rhythms, right? So your ventricular rhythms are on top, your ventricular rhythms are on bottom there, right? And it's all about the AV node. That's usually the separation point. And there is scar tissue, not scar tissue, I should say. Actually, there is non-conductive tissue between the atria and the ventricles. That's why you shouldn't get, the atria all have to go their electrical signals through the AV node. If they don't, that's called AV nodal reentry tachycardia, which usually happens in young people. You usually see it a little sooner, but not from an MI, obviously. Okay, so bradyarrhythmias due to blockage of the electrical highways. We're blocking this highway or that highway or that highway. We're blocking the AV node. We're blocking the SA node. All these things get perfusion, right? So what perfuses the SA node and AV nodes? Yeah, RCA, I heard it. All right, RCA does, right? By 60% of the time, right? The RCA feed and 90% in the AV node. So SA node 60, AV node 90. The other 10%, 40% is your left circumflex. So whenever you have bradycardias, you can see really profound ST elevation and bradycardia. You know it's either the RCA, if you're going to bet odds, right? And the other option is left circumflex. Okay. So then also the bundle of His. Now we're starting to get into the septum here, aren't we? Right. So now we're thinking about LAD and getting involved. When they start getting really, really high grade blocks, like an idioventricular block, we're thinking of a LAD occlusion. Okay. So how do you fix these? You only give atropine if it's a low grade block. If it's a sinus bradycardia, if it's a that's causing symptoms, or it's like a secondary type 1 block. But when you start with type 2 blocks, type 3 blocks, atropine is not going to work, and sometimes it can be detrimental. All right, to be giving atropine to these higher grade blocks. Okay. In the meantime, we'll give dopamine, isoproterenol sometimes, epinephrine to raise the heart rate if it can, but also it'll support the blood pressure. You usually only start these drips or medications if someone is symptomatic. Okay. And what else? So we have the tachyarrhythmias. So up here was bradyarrhythmias. Okay, bradyarrhythmias, stop drawing, there it is. And then the bottom is our ventricular rhythms that can happen. And we can have supraventricular tachycardias, and we can have ventricular tachycardias, right? So supraventricular, as we mentioned, it's an umbrella term. You can have AFib, aflutter, paroxysmal SVT. You have all these different tachycardias can happen up top. And then down below, we can start getting some VTACs happening. We got a lot of PVCs occurring, right? We got some ventricular tachycardia, VFib, torsades. All these things can be due to a MI of some sorts. Okay, and you can see the septum being fed by the LAD. All right, a little bit by the RCA, but the LAD gets occluded, then you're going to have the septum get blocked, and then you're going to have a new bundle branch block, right? You have a new left-sided bundle branch block. The left bundle is fed by the LAD. So that's why they kind of put it up there as a high risk. When someone comes in with a new left bundle branch block, we need to go to the cath. We need to assess that they have the clinical picture, and then they might go to cath lab to get that reperfused, that LAD reperfused. Okay, so that's the idea behind our electrical consequences of a MI.